So Janet, nice to see you.
Nice to meet you.
So I understand you recently had a diagnosis, and you're kind of trying to figure out what you'd like to do. I know you had a mammogram, and that ended up showing some abnormality, and you ended up getting a biopsy.
Yes.
So you have an invasive cancer component, I believe, and also an in situ. You know what that is? In situ,
No, I'm not sure.
it's when the cancer is like right on the outer surface of usually the breast ducts, most commonly, and that's the kind of cancer that can eventually become invasive and then can spread. And it looks like you've had a patch of the in situ surface cancer that has developed a small invasive cancer. But so far, no signs in the lymph nodes or any other place so far that we know of that it's spread. So that's good. And so I guess you've been talked to about the different options that are available for treating.
Yeah, just lumpectomy or mastectomy. And I just am kind of unsure. I'm feeling like, I don't really know the difference in what is really better just as far as return of cancer and most risks.
Okay. So breast cancer is one of those very unusual diseases that have kind of two different pathways that have pretty similar outcomes. So there's the option of doing the lumpectomy, which does have a higher local recurrence rate. But if you add radiation, which is about 5 to 6 weeks of daily radiation to that, then it reduces the local recurrence rate to about what a mastectomy is. That makes sense? Both treatment options have about the same survival. So one's not going to make you live longer than the other. So it really kind of comes down to whether or not a lumpectomy would, and avoiding bigger surgery, if that is a higher priority compared to perhaps a bigger surgery, but with a slightly lower recurrence rate and the same survival. And so it sort of kind of comes down to, I think, with a lot of patients, what is your lifestyle? What is your planned survivalist lifestyle going to be after this? And I don't know if you've been talked to about kind of what happens with a lumpectomy and radiation in terms of going forward, what can happen. So depending on the size of the tumor, lumpectomy can be removed, and then that cavity can fill up with fluid, and the breast can look very normal afterwards, even though there's a portion of the breast is missing. As things heal after just a lumpectomy, which takes several months, that fluid gets absorbed, and then that cavity becomes more of an indentation and a pocket, and sometimes can change the way the nipple points, because if it's here and there's a cavity here, the nipple can end up pointing here, but it will take many months for that to become apparent. The radiation that's usually added to that can sometimes make that a little bit more significant in terms of the distortion, but the techniques are much better these days, and so there's much less distortion. I would say the biggest difference is the surveillance afterwards. So I don't know. The things that I always ask patients are how important is nipple sensation? Because it's important to some people. And if it is very important to you, then lumpectomy with the post-op radiation is probably the best option for you. Mastectomy is going to leave you with numbness in the nipples, kind of undoubtedly. If you hate mammograms, if those have always been painful, and sometimes they are more painful after the surgery and the radiation because the breast is a little firmer and not as compliant to being compressed. If you hate mammograms, well, then mastectomy is the way to go to avoid that yearly reminder of the disease and the gauntlet that you would have to walk through every year for that kind of radiographic surveillance. If a mastectomy is done, then the surveillance is typically just manual, sometimes an ultrasound. And if there's anything suspicious, well, then people go right to an MRI either way. So I would say that is a really big difference in terms of, going forward, whether or not you want to sort of put this behind you or whether you mind, being surveyed every year. Nowadays, the breast reconstruction and the way mastectomies are done is vastly different than the way, say, your grandmother had a mastectomy, in which case probably she had maybe a significant portion of the skin, almost undoubtedly her nipple was removed, And then perhaps if she was far enough back, they even took muscle. So it was a very deforming surgery, historically, what mastectomies were. And then over the years, we figured out that the survival and the local recurrence rate is better than we would expect doing less and less surgery. So over time, there was a technique that was developed called the skin sparing mastectomy, where just the nipple was taken, but all the rest of the skin was left in place. Okay, and then now even more recently, in the last 10 or 15 years, the nipple sparing mastectomy is come into play because we know that certainly breasts that aren't really large, that nipple can survive, and it doesn't have to come off for your survival or for treating your cancer, unless of course the nipple's involved in the cancer, and then of course it would have to come off. So nowadays, more times than not, the incision for the mastectomy can be done underneath the breast, and then the breast mound can be removed from the skin envelope, if you will, and then we can replace that mound with usually first an expander followed by an implant. Sometimes if we're going down in size, maybe directly to an implant. And so your nipple's still there, and you have to have the radiation, so the skin doesn't typically get discolored. So quite often, if a patient chooses that route, granted the breasts and then the nipples are numb, but the result can be that you can't tell necessarily that you had a mastectomy done by visualizing things, by looking, by feeling necessarily. The same thing can happen for someone that perhaps has thought about a breast reduction in the past. And if someone's thought about a breast reduction, a couple of things can be done. You can do the lumpectomy, and then we can rearrange the breast a bit so that you don't get a big cavity indentation and nipple pointing in the wrong direction, and then radiate the breast. Nipple sensation is maintained, and if enough operative preparation goes into play, that radiation fibrosis that occurs can actually bring the breast kind of up into a good position. That is a little harder to predict than perhaps doing just a straightforward mastectomy and reconstruction, but it certainly can be done. The other thing that can be done, and this is what I do most commonly and started doing probably 10 or 15 years ago, is saving the nipple, going ahead and making the breast cancer surgeon's incisions, which are shaped like a breast reduction. And then I come into the operating room with them in the very beginning. I remove the nipple and create a little flap of skin from underneath. And then she or the surgeon does the mastectomy through the breast reduction incision, which is much wider. And then I closed, and it looks like a deflated breast reduction. And then I put the nipple right back on. And then after that's healed, or while that's healing, we expand the expander up, eventually replace that with a permanent implant. Oftentimes we're grafting fat, which is another advancement over the last 15 years. And so ultimately that patient may come out looking like, instead of having a breast augmentation, it would look like they had a breast reduction. And certainly nowadays it's not uncommon to need to tell the patient that you need to tell your primary care physician that you don't need mammograms because those are reconstruction breasts, when they may not be able to tell. So really, the mastectomy treatment and reconstructions has really come a super long way from where it was even 20 years ago. But the lumpectomy and radiation certainly has its place. It's smaller surgery, so someone with a higher risk for surgery, I think certainly. Somebody who really doesn't mind mammograms, really wants smaller surgery, and values nipple sensation, then by all means, I think that is a reason to pursue the lumpectomy with the radiation. So it's a very difficult decision for people like you to make, because you've just been diagnosed and you're thinking about all kinds of different things and probably not getting the whole story about how to make that decision. And I think it's really important that you make that decision going forward, not just for today, but going forward for hopefully the next 10 or 20 or 40 years of life, during which you're going to have to kind of follow through with surveillance, depending on whatever this decision is that you made now. So The fat grafting, I'll get back to that. So when we put in, historically, you would put in an implant, and then if the breast surgeon left skin flaps that are really thin, then you're going to see that implant right underneath that skin. So we do graft some alloderm, which is a dermal product that thickens up the coverage. But then the other thing that we can do now is we can harvest fat with fine liposuction cannulas that take little bits of fat, and then we process that into syringes, and then we infiltrate your skin with your own fat, and then that will about half that fat will take, and so it can thicken up very thin coverage to something more acceptable. And so sometimes we'll do that more than once, and then ultimately it ends up looking more like you've had a breast augmentation, especially since nowadays, more times than not, we can save the nipple. So today's mastectomy is definitely not what yesterday's was, but definitely lumpectomy and radiation has its place. But I do feel like patients kind of need to know kind of the score today and what the score will be tomorrow and 2 or 3 years from now when you're looking at what all you may or may not have to do to stay healthy. So what pressing questions do you have that I haven't covered?
So what's the difference between the expanders and the implants, and how does the expander work?
Okay. So assuming, well, when a mastectomy is done, when you take the mound of breast tissue, which is a lot of fat, depending on your age, and breast tissue, gland tissue, when you remove that and you just leave the skin, that skin's been robbed of all the blood flow that came up through that mound. So now that skin only has blood flow coming from the edges, okay? And so if we put in a permanent implant right away that's heavy and it's weighing on that skin that doesn't have the blood supply that it used to have, sometimes that skin won't survive. And then that implant can erode through. So what we typically do, most surgeons do, is we put in a tissue expander in, which is basically a deflated implant, okay? It has a little magnet on it. And so after surgery, once the skin incision looks like it's healing, then we access usually pretty numb skin with a small needle, and then we start inflating that expander. We add 100, 150, maybe 200, at a time, sometimes just 50 cc's at a time. And so gradually that expander will expand up without really stressing that skin too much at one time. So that's the purpose of it, is to gradually expand the skin as we know it can tolerate it gradually. And then once it's expanded, which usually only takes, 3 or 4 expansions, it really depends on the size breast or implant that we're heading to. Once that's done, which is just in a few weeks, then we wait about 3 months total from the time of the mastectomy to the time that you come back to a small outpatient surgery center. We bring you in. We make a portion of the incision underneath, reach in, take out deflate it, and then take out your expander. And then we've already picked out your implant size because we know what was in here, and we can tell what you need. So then I put back in that permanent implant, close up the incision, takes under an hour, and you go home same day. So commonly, that's the time when I'm also going to do a little bit of fat grafting over the implant that will thicken up that coverage and make it look more like a natural breast as opposed to a reconstructed breast.
So if I'm thinking more about a mastectomy, because I, just want all of that tissue gone, and what is actually saving the nipple bring back a higher risk of recurrence because you've gotten rid of all the tissue, but you've saved the nipple?
So the nipple is part of the breast, whereas the rest of the skin really isn't part of the breast, meaning the breast gland is underneath the skin and it kind of erupts outward with the nipple. So when a nipple sparing mastectomy can be done, usually there's a thin layer of fatty tissue and blood vessels that's left underneath the nipple, but it's super thin. So if your tumor's like a centimeter from the nipple, it probably needs to go. There's really not great guidelines about that anymore. It used to be within 2 centimeters, but now like people will leave the nipple when it's relatively close. But I would say, yeah, there probably is a slight increase just because it is breast tissue. But it's also very thin, very easy to feel, and really doesn't have the same lymphatic channels that would make a spread go right to your lymph node like it perhaps would have before, because all that's been removed. So generally, so I would think that, cancer forming in that would be a little less quickly to spread, because most of those channels are gone and it's had to reform new channels. But so it has been researched, and it is an acceptable thing. The nipple sparing mastectomy is commonly done. Now, it's not done on patients that have really large breasts or really droopy breasts, because, as I was explaining, since the mound is gone, the blood supply has to come from the edges of that skin up to the nipple. And if your breast is really large, then the very middle of that breast, which is where the nipple is going to not make it, and it's going to die. So you can really only go underneath the breast and take out the breast mound with a nipple sparing mastectomy in patients that are maybe a small C, B, A. But when you get to a really big C or a D, or maybe just a droopy, a patient that has significant droop to the breast, then what, as I was explaining before, what I do is I come in, I take the nipple off, I close it, I make the incisions like it's just going to be a breast lift or just going to be a breast reduction. They do the mastectomy, and then I close everything just like a lift or like a reduction, and put the nipples back on over the expander, and then we expand that up, and then you've kept your nipples. And but I mean, nowadays there's so many different ways of tattooing nipples on and nipple flaps. So and then there's certainly a lot of people that they don't really care, don't really want the nipples, but it is a nice thing to be able to offer now, when it used to be that they were always, had to go. So
Is there, if you move forward with lumpectomy, which they would want you to have radiation, what if it comes back again on the other side? Is there only a certain amount of radiation that you can have?
that's a great question. Actually, yes, there is. So there's a certain amount of whole body radiation that we can tolerate before we start having leukemias and other types of cancers. So having the lumpectomy and the radiation does kind of utilize a portion of that total body dosing kind of as an upfront treatment. And sometimes, and quite often, if a patient's unfortunate enough to have a spread to the spine or someplace where they have pain and they now have metastatic cancer, then the radiation that's used to control those symptoms may or may not be as effective. And certainly you wouldn't have the same dosage to treat for palliation or comfort with radiation that you would have had you not have used that. And there is some research to suggest that if you radiate a tumor up front, then if it ever comes back 5 years later, it's just not going to react as much to the radiation, because what's there is what survived the radiation to begin with. Does that make sense? So yeah, there is that. And then as far as like the opposite breast, I mean, I really feel like, well, let me say this. I think that reconstructions that are done, and they are done in the same manner in both breasts, because they both have the same mastectomy, they both have the same breast reconstruction, that's going to give you the best symmetry. Okay, just in general. It's a lot harder to match a breast implant reconstruction to kind of a droopy or more mature looking breast with some hollowing at the top. Mm-hmm. Now, for those patients, insurance covers a lift. So we can do lifts, we can do breast reductions on the opposite side as well. So, I mean, I feel like if patients have a significant family history or just quite significant angst about the opposite breast, that I think they need to talk to their breast surgeon about the prophylactic contralateral mastectomy, especially if it can be done as a nipple sparing, because they're going to have better symmetry. And then without it, they're going to need a mammogram on that side, even though maybe they had a mastectomy on the other. So then they're always coming back for a mammogram with uneven breasts. But again, if nipple sensation is super important, then leave the other breast alone. So, I mean, it really has to be tailored to the person and what their desires are, and how important sensation is, and how important it is to avoid the medical industry and mammograms going forward. But those are all really important considerations to take into account that really aren't often really ever discussed, sadly.